Hey guys, I'm Andreas, and welcome to another Study With Me video. And I'm so happy you can join me. And I know that I always say that in my videos, and it's not just because I want to say it, it's not just for show. I say that because I know these videos are designed to help someone who wants a study buddy, and I really love that. But I think I get a lot more of these videos than what my viewers might get out of them. And I say that because I know I always try to stay in high spirits and all that, but the truth is, this year has been extremely difficult for me. Um, it's not just with school. It's just like I feel I work hard. I try hard. Look at my eyes; they're bloodshot. Like I always put my best foot forward, but time after time, it seems like I'm always one step behind. This not a lot has worked out for me this year. Um, I'm not gonna get into that, but at the same time, it's difficult to study. And I say this because like I said, I make these videos for someone who needs a study buddy, but by that thought in my mind, I don't care if one person or two people or 2,000 people watch this video, the thought that there's someone out there who wants these videos and needs these videos motivates me to keep making them, and it kind of motivates me to study. So that's why I always say thank you, because you guys just keep me going. It's hard nowadays for me to put my best foot forward, and I'm trying, guys. Don't it's not This is temporary. I mean, you can only be down in the dumps so long, but at the same time, guys, thank you, thank you, thank you. So tonight, I usually tell you guys what I study. I'm doing palm and cardio, and it's been slow. I've been feeling down, and I've been studying down, but I got this, guys. You got this too. Um, you just gotta, you gotta realize that only you can change your life. And nobody cares about your life a fraction as much as you should about your own life. So, with that said, like, you just gotta always work towards the goal, whatever those goals are. You gotta have a clear mind. You gotta have some sort of drive. You just. And right now, guys, I'm not gonna lie to you. I feel like I'm in a spot where I spread myself too thin sometimes. And with that said, you get like analysis paralysis, and sometimes you don't just like. I'm so overwhelmed that I can't do anything. And I know I don't like to admit this because a lot of you guys think I'm out some like I don't know, like some perfect, especially when it comes to Instagram and all that. But that's not the case, guys. Like, I struggle just as much as the next guy, and yeah, it's tough to admit that, but it's the truth, guys. And take it day by day, and who knows? Who knows? Maybe something good's coming my way, something good's coming your way. All right, so let's get to studying. Let me start the timer, and I'll just keep this on, whatever. And I'm not cussing while I'm studying. Okay. Come on, let's make a good push tonight, guys. Let's finish hard. Let's try our best. Okay, so we have basics. 628. Okay, so we have some certain medications when it comes to medications and their side effects here. So we have your theophylline here, good, which are your methylxanthines, which are going to be your theophylline here. Now theophylline here, they're gonna inhibit bronchoconstriction, so they cause bronchodilation by being a phosphodiesterase inhibitors, right? Now the phosphodiesterase inhibitor, okay, by that said, okay, good. They're going to reduce your cyclic AMP, but the thing with your methylxanthine theophylline here is that they have a narrow therapeutic window. They can cause you to have hypotension. They can cause you to have arrhythmias here. What else can they cause you? Let's see. So again, they're going to cause you to have your seizures. Good. So again, we're going to have bronchitis here. So they're going to have tremors here, hypotension, tabs here again, tabs. So we have your VSHAT, good. Let's put that down. VSHAT, so it's going to cause you to have your which is going to be vomiting. We call it vomiting here, good. Seizures here, tremors here, hypotension, and arrhythmia. That's what's going to be done as well. Now again, when it comes to your long-acting beta-2 agonist here, what are the side effects from there? Again, I know they're going to tachycardia here, good. Tachycardia, good. Arrhythmias. Hypokalemia, good. So it's going to cause you to have tachycardia here, good. Hyperglycemia here, arrhythmias here, tremors, and also hyperkalemia. So it's going to cause you to have tachycardia here. It's going to cause you to have your hyperglycemia here. You're going to have arrhythmias here, tremors here, and hypokalemia. Hypokalemia, good. It's going to be your that. It's going to be your that age, good. Get back to that one. Now, let's go over here real quick for Pete's sake. Good. We have this. No, I'm good. Now we have for cystic fibrosis here. What are the growth chart look for children? So growth chart in children, when you look at it, again, I know they're going to have like failure to thrive here, so let's go through that as well. And then we have remember it's going to be Staphylococcus aureus here, Pseudomonas vaginosa. You're good. That Pseudomonas recurrent respiratory infection here. It's going to be Pseudomonas here for adults here. How do you treat that? You treat it with your meropenem, tobramycin plus meropenem. You're good. And then what about Staphylococcus aureus here? We can do your vancomycin or linezolid if it's MRSA, or you can do your you can have your ampicillin, ampicillin here. It's going to be your susceptible as well. Good. The complications, remember for children here, you're going to have your meconium ileus, which you're going to have usually you're going to have failed meconium within the first 24 to 48 hours here. So it's going to be your meconium ileus here, which you're going to have your thickened, you're going to have obstruction of the distal ileum here due to like thickening of the distal ileum, causing an obstruction. And I know you can do your barium enema here, which is going to show what? Let's go through that. Complications here is that you're going to have, okay, good. Now we're going to have your band here, good. So it's this component. Now here is that you're going to have your band here. You're going to have your biliary. You're going to have your biliary vomiting, abdominal distension, and no passive meconium here, good. And then your diagnostic is that you do a contrast. So you do the diagnostic. You do an abdominal X-ray here, then you do a contrast enema here, good. So remember, you're going to do the abdominal X-ray. It's going to show dilated bowel, dilated loops of bowel here, good. And the contrast enema is going to show your microcolon, good. Microcolon, good. Which so again, you're gonna have abdominal X-ray. You're gonna have your abdominal X-ray, your abdominal X-ray with the contrast, which is gonna show your soap bubble, dilated loop soap bubble, which is gonna be your new Eaton sign. And then you're gonna have to do your enema. And then you're gonna have to do your barium enema. And then you're gonna contrast enema. So again, you do your abdominal X-ray here, which is gonna show you to have which is gonna show your dilated loops of bowel here, good. And then you're gonna do your you eat the contrast enema, which is gonna show you your microcolon, which is gonna be Newson sign. So no soap bubble appearance, dilated, which dilates about, and then now you're going to do your mic, and then here's your enema with contrast. Got your enema with contrast. Now you can have core pulmonary. Remember, you can have pulmonary emphysema. You can have pulmonary emphysema here, core pulmonary or core pneumothorax as well. Good. And then prevention over here, prognosis and prevention. Get this wet. I can stick. We have complications here. It's going to be, remember, you can have your pulmonary embolism, you can have your pneumothorax here, you can have your core pulmonary here, and pulmonary emphysema as well. Good. The prognosis here is going to be individual fibrosis. Now again, the prevention. So again, annual influenza. So again, how do you prevent this? Pneumococcal vaccine here, and annual influenza. Annual influenza for all affected individuals, like in 6 months with an activated good influenza for all affected. So here, so prevention here is that your annual, you have your pneumococcal vaccine here, and your annual, if you're affected, annual influenza for all affected for 6 months or longer as well, good. Activated vaccine. Now, the main life expectancy, good, bronchitis here, good. The main determinant of expectancy is the severity of pulmonary disease. So again, yeah, you can develop your bronchitis and progressive respiratory good. Remember, you can have your, what's happening is that you can get chronic respiratory infections here, good. Chronic respiratory infections. And you're going to have mucus plugging. You can have chronic respiratory infection, mucus plugging, fibrosis here, good. You can have bronchitis here, which is going to be reversible, good. Bronchitis. And then you have progressive respiratory failure, and then death usually as well, good. And then individuals so again, you have symptoms in late childhood, early adult. You only have them on the course. Individuals have pancreatic disease, mainly pulmonary symptoms in late childhood. So again, when you have pancreatic disease, then you're going to have good. So again, we like this here to have failure to thrive here, so impaired growth velocity. So you have impaired growth velocity, which is going to cross two or more percentages. Again, You're going to have usually failure to thrive here, and you're going to have impaired growth velocity. You're going to see that as well. Good. Good. We have this one in the prognosis here. Usually, the prognosis depends on the degree of pulmonary disease here. So if you have recurrent chronic pulmonary disease, events of happening in mucus plugging, you're going to have reverse bronchitis. You're going to have progressive respiratory failure, then you're going to have death. The prevention here is that pneumococcal vaccine, you're going to affect individuals here. You have inactivated influenza 6 months or greater. That's well. Good. Now, what do we have here? So pulmonary embolism and all different things here. So let's go through 644. So again, when we talk about your pulmonary embolism here, so we use the Wells criteria to diagnose it. So based off the Wells criteria, let's go through that here. So if you're going to have a score 5 or greater here, good, then it's going to be 4 or less here, low risk here. Anyone who has 5 or greater here, good, they're going to have a high risk of, so you're going to have you're going to put them on a empirical anticoagulant here, good, and unless contraindicated. After, if it's contraindicated here, you put them in if you're indicated filter afterwards as well. So again, when you do this here, it's going to be so it's going to be your PMH here. So again, if you have symptoms of DVTs or on embolism, that's going to be 3. History of DVT, that's going to be 1.5 here. If you're going to be mobile here for good, it's going to be tachycardic here, it's going to be 1.5 here. If you're going to have post surgery here, which is 4 weeks after surgery, within about 4 weeks, 1.5 here, and hematopsis and malignancy is going to be 1. Good. Post-op here, good. Good. And then how do we treat this? And if you're going to have any sort of good. I think we said that as well. So we have this we have referral. So if it's going to be no contraindication to it, then here it's going to be high surgery robotic, and then if moderate to low here, and then we're going to moderate to low here during diagnostic confirmation. This is and you start like after that here, good. It's going to be seen as well. What are contraindications to anticoagulation? Can be PRISC here. So first off, it's going to be no bleeding disorder here, gets your hypertension 180 or 110. It's going to be your ischemic stroke in the past 6 months here. It's going to be recent major GI bleed or previous intracranial hemorrhage here. Good. As well. That's surgery as well. And then when we look at this here, how do we do this here? So we have so first off, we have hemodynamic stability. The patient's going to be hemodynamically unstable. What does that mean? Hemodynamically unstable. Then we want to stabilize them here. So we give them IV fluids here around 200 to less. You want to give them less than 500 milliliters of fluid here to stabilize them. Because you want to prevent fluid overload here, which is actually going to further decrease right ventricular function and decrease cardiac output. That's what we're going to do as well. Good. So if they're stabilized, what do we do? Immediately here, we're going to do your contrast CT, your CT pulmonary draft, your CT, your contrast CT, your CT contrast CT pulmonary draft. Good. That's going to be your episode show that here that. And then we contrast CT chest, contrast contrast CT of the chest here again. But if you're going to have any elevated GFR or low GFR or elevated creatine levels or brains here, then we do ventilation perfusion here again. That's high sensitivity and specificity as well. Good. Yeah, good. Yeah, specificity as well. Good. And then patients who are your bedside transfer echocardiogram. If you're going to have ventricular dysfunction, you're going to treat them. You treat them for automatically for what? For pulmonary embolism. Good. And then here, you do Wells criteria. It's going to be less than 4, less you're going to D-dimer test. And if it's going to be 500 or greater, then you're going to move to the petition. Good. Good. That's going to be then treating pulmonary. That's going to work out good. Now, when you have someone who has members, so you're going to have acute sudden onset of shortness of breath. You're good. Periodic chest pain and chest pain. You're good. And also you're going to have low grade fever here. You're going to have low grade fever, not cough here. Low grade fever, tachycardia, you're good. You're going to tachycardia, you're good. That's what it's going to be as well. It's going to be as well. Chest pain, fever, cough, and fever, cough, and everything. That's good. That's what we're saying. Now understand here that in this case here, okay, good. And then here you're going to have your respiratory alkalosis to attack here, but you're going to have with hypoxia as well. PaO2 is going to be less than 6 with hypoxia as well. Good. Respiratory alkalosis here, which you're going to have with hypoxia as well. Good. So again, respiratory alkalosis, hyperventilation as well. Good. And then chest X-ray. What you do, it can be normal here. You can have evidence of what 8 lactases here or pleural effusion. You can see as well. Also, you're going to have your Westermark sign here, or you're going to have your watermark hump here, which is going to be what? It's going to be your coastal, which is going to be your coastal blunting here, or which is infarct. Hampton hump, which is infarct, or Westermark sign, which is going to be we're going to have collapse of the vessels to the obstruction as well. And then again, last thing is if we do your EKG here, so initial sign of tachycardia here again, and your true sign of tachycardia again, to show your increase in centimeters pressure. We're going to increase right atrial pressure again, right atrial pressure as well, okay, which you're going to see as well, right atrial pressure as well, good. Now key factor, you're going to see someone who has chest pain here, good, who has a history of sitting in a while here, good, but normal EKG, usually it's going to be pulmonary embolism as well, good. Now management for this one here, so inferior anticoagulation here, which is going to be direct oral. Again, we can have direct oral anticoagulation again, or your again, which are going to be again, or you can Lomecel-B and Daxxifan here, or infraction heparin as well. Good. Now these are going to be the choices here. Remember, it's going to be anyone who has cancer as well as anyone who has a normal. Good. But if you have renal failure, you're going to use infraction heparin. Good. Then from there, what do we do? We give your fraction heparin, like we said. Good. Fraction heparin plus your fraction heparin or your Lomecel-B and Daxxifan here for about 5 to 10 days. Here. Good. Then we're going to do what? 5 to 10 days, and then we're going to do then we're going to translate to warfarin here. Good. For about 3 months here. Usually less than 3 months here. 2 to 3 as well. Good. 2 to 3. If you're going to be, if you have cancer, you're good, or if you're going to have unprovoked pulmonary embolism, you're going to do definitely is good. And then those who require, then also you do inferior vena filter, those who have found indications to anticoagulation here, or those who have emboli forming despite the anticoagulation, inferior vena filter as well. Now all patients here at DD provides that there's going to be early embolization, that's the best here. Good. Remember, compared to the worst here, also you can have low dose subcutaneous heparin or low heparin as well. Good. That's going to be seen as well. Good. If you have a massive pulmonary embolism, you can do thrombolysis here with a thrombolytic here, which is usually going to be what? Alteplase, Vectibase, Vectibase here. Good. But if that fails here, you can do embolectomy. Embolectomy as well. Now, complications of cerebral accident. So you can have right ventricular dysfunction here. Good. Again, you can have your right ventricular failure, or psychotic pulsation activity, so right ventricular failure, just so you know as well. Good. Now meds here. So remember your asthma meds here. Remember it's going to be your short-acting beta agonist here. Good. It's going to be albuterol here to cause bronchodilation, which is going to bronchodilation here. Good. And then also we're going to have your long-acting beta agonist here. Good. It's going to cause you to have fats here. It can cause you to have tremors here. Good. It can cause you to have hyperglycemia here. It can cause you to have arrhythmias here. And also it can cause you to have tachycardia. And also it can cause you to have hypokalemia. Don't forget that. And then remember your theophylline here, methylxanthines here. Again, phosphodiesterase inhibitors here reduce cyclic AMP, which causes bronchodilation. That's going to cause you to have your VSHAT, which is going to be what? You have tremors, vomiting here, seizures, tremors here, hypotension, arrhythmias. Good. Now, we have your pleural effusion here when diagnosing. Good. When diagnosing. With an heavy pleural effusion, what do we look for? Good. Now, let's go through step 2, pleural effusion. Good. Move over a little bit. Pleural effusion, so pleural easier. So when you have pleural effusion, that's just going to be fluid within the pleural space, like we keep saying as well. Now accumulation of fluid within the pleural space. Now overview here. Let's go through this here. So overview here is that we're going to have your 2 classifications. Let's go through this. So we get the overview here, which is going to be the types. We have your transitive or exudative fluid effusions here. Good. Which is going to be same over here as well. So transitive exudative effusion as well. Good. And then use the etiology, which is going to be the cause of them here. It can be seen as, so we can use the book for it. Good. So we're going to have exudative effusion as the cause here, and then we're going to have your clinical features and all the different things as well. Good. Then we're going to have your book for the diagnosis here. So, okay, so when you have pleural effusion, that's going to be just fluid within the pleural cavity, like we keep saying, okay? And then, the etiology, we can either have your transudative effusion or exudative pleural effusion as well. Good. Now, again, abnormal fluid pleural space, the transudative here is that you're going to have secondary to increased pulmonary capillary pressure. So this can be either, okay, transitive here, it can be increased into pulmonary capillary wedge pressure, good. Or it can be due to reduced oncotic pressure, good. So capillary oncotic pressure, like we said, good. So yeah, and this is going to be for vascular permeability. So again, we're going to have transudative here, which can either be due to increase in your pulmonary capillary wedge pressure, which also known as your capillary hydrostatic, which is the hydrostatic pressure, increased hydrostatic pressure, or it can be due to decrease in your capillary oncotic pressure as well, good. Or it can be due to capillary oncotic pressure, like we said. So again, we're going to have yours. We have good. So it can be due to a decrease here in your capillary oncotic pressure, good. Or it can be due to increase in your pulmonary capillary pressure or hydrostatic pressure as well. And then that's going to be transudative here. Now exudative here, this can be due because you're going to have what? You're going to have increase in your pleural. You're going to have increased capillary permeability, increasing your due to capillary permeability as well. Good. Permeability as well. Good information. Now, what are the causes when you have all these here? And let's go through all these here in terms of the book as well. Good. Now here, then we have the list criteria here, and then we transudative or exudative as well. So we do diagnostic therapeutic as well. Now again, how to present there is that you're going to present with you're going to have dyspnea. You're going to have dyspnea here. Good. Clinical features, symptoms, and CT. So here again, we have your transitive and different things as well. And then we're going to have dyspnea. Good. Both. As for that here, so you're going to have dyspnea. You're going to have shortness of breath here, bloody chest pain, and or cough as well. So you're going to be dyspnea here, good, and bloody chest pain, and non-productive cough, trying non-productive cough as well. Reveals tolerance, progression, reduced breathing sounds, and sounds on the table. Good. That's going to be as well. Good. So again, you're going to have dyspnea here, good. You're going to have bloody chest pain, and you're going to have dyspnea here, good. Dry cough, non-productive, dry cough as well. DPD, dyspnea here, bloody CPD, bloody chest pain, and dry non-productive cough as well. This is the underlying disease. So then also you're going to have symptoms, and then here as well, good. And then on physical exam, what are you going to see? You're going to have your dyspnea, good. Dry cough as well. And you're going to have pleural friction, good. And what are you going to see? You're going to have pleural friction, auscultation. And what else are you going to see? You're going to see asymmetrical chest wall, reduced center firmness. Pulse progression. So you're going to have, you're going to have your asymmetrical expansion. You're going to have reduced firmness, like we said. You're gonna have what else? You're gonna have your decrease your absent breathing sounds, decrease breathing sounds here, good for the effusion, tolerance to progression, and also progressive friction over here. So again, you're gonna have your DPD. So you're gonna have dry cough here, bloody chest pain, and dyspnea as well. And also you're gonna have your productive friction over here, good. You're gonna have decreased breathing sounds over the effusion, tolerance to progression as well, and reduced firmness here again, and reduced firmness. Right, for the effusion, which is gonna be reduced firmness as well. Good. Reduce firmness as well. Now, what do we see when it comes to the different things where to go? Guys, sometimes I get really hot and I have to turn on my AC real quick, so I'm going to mute the microphone so you don't hear it. There. I hope that mute tone doesn't do nothing. Whatever. I'll just mute it from here. So again, IPA can be just like pneumonia here, which is a pneumonic effusion here. It can be tuberculosis or your pleural emphysema here, pleural emphysema, good infectious causes. And then again, it can be malignancies. It can be your actually it can be infection. It can be your cardiothorax here, good. Left side and different things here. So we have different things here. It can be due to IP. It can be infections. It can be also it can be due to pulmonary embolism. So like IPA. It can be autoimmune, which is arthritis here. Pancreatitis can be your what can be pulmonary embolism. It can be your PAP. It can be infectious causes here. Pneumonia, which is going to be your pneumonic effusion here. Again, it can be due to pneumonia, tuberculosis, or pulmonary pleural emphysema as well. Pleural emphysema can be due to pulmonary embolism here. Good. Also be autoimmune diseases like stomach obstructive here. Rheumatoid can cause as well. Good. Also can be your pneumothorax. It can be your pancreatitis, hemothorax, chylothorax, and pseudochylothorax here. Again, your hemothorax, chylothorax, and pseudochylothorax here, and also your pancreatitis as well. Good. Also malignancies, which you see in lung cancer, mesothelioma as well. Good. Can be all the cause. Further workup needed. Further workup's going to be needed as well. Good. Further workup's going to be needed. Now, when you look at this here, is that we can have different causes. So when you have your pleural protein compared to your pleural protein compared to your serum protein when you're 0.5 or greater here, that's going to be what we're going to be. That's going to be actually good. When your pleural LDH is greater than 0.6 compared to your serum, good. When it's greater than the upper limits here of your LDH here, good. That's going to be 2/3. That's going to be your agitated as well. Then we have two types. It can be due to IPA, malignancies like lung cancer, mesothelioma here, infections like your pneumonia here, which is pneumonic effusion here, good. It can be tuberculosis here, and also tuberculosis, and your pleural emphysema, I guess, and what's going to be called pleural emphysema, and then also it can be due to infectious. Also pulmonary embolism, don't forget that, and also it can be due to autoimmune here, like rheumatoid arthritis or something that's that's another one. Also it can be due because you're going to have your chylothorax, pseudochylothorax here, hemothorax here, and also your pancreatitis here, and also it can also be due because you're like we said. Good. Where it's going to be needed as well. We see it as well. Good. It can be translated as well as it's going to be seen as well. Good. Like we said. Panic atothorax. So cirrhosis is going to be panic atothorax as well. It's going to be what? It's going to be pneumonia. So we have this one again. We have this one which is going to be cirrhosis here, which is going to be your panic atothorax again. That's easy. So CNC is going to be congestive heart failure here, which is going to be, remember, congestive heart failure, your insidious disease there, and also we're going to have your pulmonary. Good. So we're going to have good. So we're going to have CNC here, congestive heart failure, good, which is going to be due to an increase in your electrostatic current, pulmonary blood pressure, good. You're going to have nephrotic syndrome here, which is going to be, you're going to have your nephrotic syndrome, and also you're going to have CNC. You're going to have nephrotic syndrome, you're going to reduce to your, which is going to be reduced to your, caused by, so increase reduce oncotic pressure, good, and also you can have your cardiac pressure, and also you're going to have your CNC, also cirrhosis here, which is going to be a panic atothorax, good, reduce good. The other one here is going to be this one as well. We're going to have IPA here, we got triglycerides here, cardiovascular disease as well. So when you look at this here, it can be IPA. And malignancy here, lung cancer, mesothelioma there, infectious causes, which is pneumonia, which is pneumonic effusion as well. And also what else we have? Good. And also we're going to have your, how can it be infectious causes here, good. And also being due to, your, P stands for your pulmonary embolism, we said over here, good, pulmonary embolism, we said. Also we can have your autoimmune cardiovascular disease, here. Good, and also your, don't forget that. So you're going to have pancreatitis here, good. You're going to have your chylothorax, your side, blue chylothorax, and pneumothorax, good. Don't forget, good. And then also we're going to have your, good, and then we're going to, good. And then we're going to have, we have here. So we have the book to the table, and then we have the analysis and the things. Now, we have your lung, we have pneumonia here, good. We have a lobar pneumonia here, which is, we have a lung consolidation, which is lobar pneumonia. And we have comparing your pleural effusion, and then your pneumothorax here, good. Pneumothorax here, what are you going to have? You're going to have decreased diaphragm this I know for this one. You're gonna have hyperresonance here. You're gonna have good. You're gonna have hyperresonance on percussion. You're good. You're gonna have increased diaphragm. You're gonna have decreased diaphragm this. You're gonna have reduced breathing sounds, reduced rapid breathing sounds here. Which is some difficulty. Decreased good. The crackles, no crackle, after crackle as well. Good. And here, remember, it's gonna have your for your pneumothorax here. Is that you're gonna have your contralateral opposite tracheal deviation. You're good. And also medial sinus shift as well. Good. And then ipsilateral lung compression as well. And inferior line as well. Good. And then what about when it comes to someone who has your pleural effusion here? Is that here's that you're going to have a contralateral mediastinal or tracheal deviation as well. Good. What else are you going to have in terms of percussion? You're going to have your hyper. What's going to be sino? You're going to have your decreased breathing sound. You have to breathe events, right? On effect down. You're going to have dullness percussion. Dullness percussion. Let me say. And the diaphragm is there. That you're going to have decreased. You're going to have decreased diaphragm. Decreased diaphragm. Decreased diaphragm here. You're going to have decreased breathing sounds. Good. Decreased breathing sounds. More decreased breathing. Good. And then after crackles, but you're going to have your pleural friction. Pleural friction. Remember that. Good. Look at that. So you're going to have dullness percussion. Good. Decreased diaphragm. Decreased breathing sounds. Decreased breathing vision. After crackles, but you're still going to have the pleural friction as well. Now when it comes to lobar pneumonia, right, which is the lung dilation, lobar pneumonia, percussion. Again, you're going to have dullness percussion. Good. Diaphragm. Increased diaphragm. And your breathing sounds are going to be fucking. For the breathing sounds, for rocket phony, I think present, often present as well. Good. Good. See that? Here. So again, when you look at it, when you look at this here, is that you're going to have consolidation. You're going to have lobar pneumonia consolidation here. Plus you're going to have here's that dullness percussion. You're going to have increased diaphragm here. You're going to have bronchial breathing sounds here. Egophony, bronchophony, good. And then you're going to have present, good. Can be seen. Now, like this is what you're going to have. You're going to have decreased breathing sounds again. You're going to have dullness percussion here, good. And also you're going to have your dullness percussion, decreased breathing sounds, and you're going to have your decreased breathing sound, dullness percussion, and what else you're going to have? Dullness percussion and decreased diaphragm. And also you're going to have tracheal deviation, towards. Then like this again, tracheal deviation towards the like this. Good. 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 Okay. So again, we're going to have your lobar pneumonia here, good. Lung dilation, lobar pneumonia here, which again you're going to have hyperresonance. That's a big one here, good. But you're going to have percussion here. Is that you're going to have dullness percussion. Like I said, dullness percussion. You're going to have diaphragm. This here. Is that you're going to have increased diaphragm. That's another one here. And then you're going to have bronchial breathing sounds here. Egophony, bronchophony here, good. And present crackles as well. Now what about for someone who has your pleural effusion here? So pleural effusion, again, what we see is that you're going to have a mediastinal shift here, mediastinal shift away, and tracheal deviation away from the effusion as well, good. Also you're going to have, don't forget hemothorax, you're going to have hemothorax, I forgot that one, good. The diaphragm, what's that going to be? You're going to have dullness percussion, you're going to have decreased diaphragm here, decrease your after breathing sounds here, and then you're going to have decreased blood, decreased open vision, and crackles absent, but you're also going to be pleural friction. Now then, when you look at someone who has your pneumothorax, remember hyperresonance here, you're going to have, what else you're going to have? Hyperresonance here. You're going to have decreased diaphragm here. You're going to have your decreased breathing sound after breathing sound. You're going to have decreased throat vision here and absent crackles here, like we said. And you're going to have your away from each sound shift and tracheal deviation away from the lesion as well. Okay. And then someone who has atelectasis here, it's going to be mediastinal shift towards and towards atelectasis here. You're going to have dullness progression, decreased breathing sounds here, and decreased diaphragm. That's good. Good. Excellent. Good. Now, let's just go through what we have so far in terms of this is a long one. In terms of what we have, and then sort of we're going to do this chest X-ray, which is for your pleural effusion. We do chest X-ray, which is going to show what costophrenic disyphysis, bladder costophrenic angle blunting as well. Other we're going to do your diagnostic thoracentesis or thoracentesis here. We're going to use, and that's what we're going to see. Good. We're going to see as well. Good. And then we have this one. Okay. Now again, when you look at the diagnosis here, in terms of how we're going to diagnose it, we have to do the costophrenic angle, and then we just kind of shift here, and then tracheal deviation away from that. Good. Yes, we got it. So here's our effusion over here. That's the larger. This right here is the effusion and tracheal deviation away. So you're going to have the large effusion. Then remember, when you have large effusion, what can you have? In large effusions here, what do we have? You can have in large effusions here. Remember, you're going to have mediastinal shift away, right? You're going to have a large effusion, mediastinal shift, tracheal deviation away from the lesion. Good. Good. Then we have your diagnosis. Okay. Now, then we have how we're going to diagnose this here. So we have diagnostic thoracentesis, thoracentesis here. Good. And then we have. So we're going to use light criteria for the effusion. You're good. We're going to use that. further workup right there. Again, now we have this. Again, we have the criteria we need. Now pH here, transitive or executive here, good. Now tentative here, we have a pH between 7.4 and 7.55. Or remember, exudative here is more acidic, less than 7.4. This is going to be 7.4, 7.55. And this is going to be usually less than 7.4. 4 as well, good. That's the pH. Video views and other things that we have to say as well, good. Now again, your transitive here, this is going to be less than 0.5 here, less than 0.6 here, and your upper echelon of the plurality, you're less than 2/3, good. And then pH here, there's usually going to be 7.5, usually going to be what? What's the pH here? It's going to be 7.5 to, so it's going to be about 7.4 to 7.55. While transitive is going to be less than 7.4, and you're going to have all these being greater as well, good. And then we have plurality H here, so plurality H here, remember plurality H here, can be less than, so less than 200, it's going to be greater than 200, which is simple. As well for cholesterol, and then cholesterol here is going to be more. It's going to be greater than 55 here. It's going to be less than 200. So again, this is going to be less than 200 here again, and less than, which is less than 45 in cell and the cholesterol. Good. Good. Then we like the physical appearance. We have one that's going to be clear, and this is going to be cloudy. Good. So it's going to be clear, transitive here, and it's going to be cloudy. It's going to be agitated. Good. And then we have your glucose levels, 7.3, 7. Good. Good. And then we have your 60 or greater here for transitive here, and this is going to be less than 60. 3% as well. And then we have exudative, we're going to have to do it. Exudative fusions here, we have further workup here, which we're going to do what? So we're going to work up here with pleural fluid, glucose, cell count, cytology, and all these different things will come. As well. So again, we have them, we're going to have here, so again, transitive here, exudative here, good. Now it's going to be less than 200. And your pleural DH here is going to be greater than 200 as well, good. pH exit is going to be anywhere 7.3 to 7.45, 7.4, this is going to be 7.4 to anywhere 7.5 as well, good. 7.5 as well, good. And then we're going to, this is going to be clear, this is going to be usually cloudy color here, and the glucose actually is going to be, we're going to have some greater cholesterol here, less cholesterol, it's going to be less glucose here, greater glucose, good. Easy like that, good, and then it's going to be this over here, so it's going to be less glucose, good, good, as well, good. And then we have different things that we have to say. Now, we're going to have presence with, presence of complicated treatment. Presentation of a complicated perineumonic emphysema. Perineumonic. So again, present. Remember, your transitive effusion require further workup? No. We have the pleural fluid analysis here. How we're going to do it? Exudative requires further analysis. This one's hard. This one's so long. Jeez. Okay, so we have so again we do cell count here again. So again, when you look at your we have a couple things here. Remember, if you're run by the cell count, it's going to be 5,000. We look over hemothorax here again. And if the hematocrit is going to be greater, than if hematocrit is greater than 0.5, 0.5 half the peripheral hematocrit, it's going to be hemothorax. And then we have, if your pH here for transitive is going to be under 7.2, we're looking at your CMC as well, good, which can be what we're going to be. It can be complicated. We're looking at complicated perineumonic fusion. What else can it be? Emphysema here, malignant infusion here, good. Cardiovascular disease here, or it's going to be your plaque preparation. So again, if it's going to be pH here, it's going to be less than 2 again. Malignant infusion here again. Esophageal perforation. Your cardiovascular disease here again. Your complicated perineumonic infusion here, or your emphysema here, good. Complicated perineumonic infusion, emphysema here. Cardiovascular disease here. Esophageal rupture, esophageal perforation, or your malignant infusion as well, good. glucose here is less than 60, what's that going to be? It's going to be usually indicative of BMI. BMI, again, BMI, and then normal BMI, and normal cytology is going to be malignant diffusion. And then here, and what else we have to do? Lipids here for this one. So triglycerides here, it's going to be triglycerides over 110. Good. Chylothorax here, 110. That's going to be chylothorax. And if the total cholesterol level for this one is going to be greater than 200, good. Or you have certain total cholesterol triglyceride level is going to be greater than 1. You're looking at your pseudocylothorax. And then if you're going to be your total cholesterol is between 55, chylothorax as well. Good. Now, then cloudy milky, that's going to be chylothorax here. And then Peru is going to be other way different things as well. Good. Chylothorax as well. And then we have transitative, it's going to be usually clear and has decreased cell count, has low level of proteins and albumin, LDH. And then exudative here typically appears cloudy and increased cell count, high levels. That makes sense as well. And then meat, so again, meat is a low glucose here, that's really good. Malignant effusion, again, malignant effusion. Your BMI, arthritis here, which is going to be your autoimmune transfusion here, good, which is going to be good for pleurisy. Tuberculosis causes pulmonary effusion, local glucose level, good. And pleural fluid with blood is going to be it's going to be significant of malignant effusion or going to be hemothorax as well, good. So we look at someone, so when you have someone who has exudative effusion here, good, that requires further workup, that's all that's saying as well. So again, someone who has a pleural effusion here, this is going to be fluid within the pleural space. It can either be transitative or exudative pleural effusion here, good. Now this is going to be transitative, can be seen because you're going to have either a decrease in your oncotic pressure, you're good, which you see that in like nephrotic syndrome, you're good, or your cirrhosis here, which is going to be cirrhosis. Okay, cirrhosis, which is going to be your which is going to be your hepatic fibrosis, and then or you're going to increase in your hepatic lung fibrosis, congestive heart failure, and sacral lesion, no good. And then what about when you have exudative? It's going to be increase in your pulmonary cavity permeability here, and you're going to see this with infectious causes here. You're going to see this pulmonary embolism here, good early on. You're going to see this with no pulmonary embolism, like we said. Also, you're going to see this in autoimmune causes here. We call it vascular disease, like we said. Also, you can see this in you can have a malignant pleural effusion, which is lung cancer or mesothelioma. Infectious causes here, it's going to be, remember, due to pneumonia here, there's going to be pneumonia, there's going to be peripneumatic effusion. That's what it is, continue that one. Also, going to be tuberculosis here, and also going to be tuberculosis, and again, we have to get this one over here. What about, then you have pulmonary embolism here, and then malignant effusion, then you're going to have vascular disease, which can be one. It can be due to rheumatoid arthritis here, some managed causes as well, and then also also going to be pancreatitis here, chylothorax here, and hemothorax, so we get that as well. Cholesterol for that one as well, good. Really good. And then we have your fusion here, good, don't forget that. Don't forget this one. Which is going to be your, we have this one with pleural BM, don't forget the pleural BM, which is going to be your exudative as well, good. Now, this is not going to, this is going to be exudative as well. Next to it has your here, so you're going to have what? You're going to have DPD, good. You're going to have dry cough here, you're going to have pleuritic chest pain here, and dyspnea, good. Also, you're going to have your pleural friction rub here, good. Also, you're going to have your decreased breathing sounds, you have to breathe out the side, dull percussion, and dull percussion, decreased breathing sounds here, and what else can you see? And decrease that from this, good. You do that from this, good. Then usually you do that, you can do chest x-ray first here, good, which is go coastal phrenic angle blunting here, lattice position here, good. Remember for lower diffusion here, you're going to see the diffusion here, good. You're going to have your tropical meter center deviation away from the lesion, good. And then, good, that we said as well. And then what else we had to do there? And then here we're going to do a diagnostic thoracentesis here, where we look at the pleurocentesis, where we look at the pleural fusion, and if it's going to fit Light's criteria here, what is it going to be? Any one or more Light's criteria is going to be your, if it's going to be over 0.5, your pleural protein to pleural, to your serum protein levels, or your pleural LDH here, 0.6 to your serum LDH here, or it's going to be a greater than 2/3 the upper limit of your serum LDH here. It's going to be these are going to be, exudative, going to be translated, good. It's going to be, remember, exudative here requires further workup, for the test around 16 miles, good. Now, again, we're going to have the, unilateral, pneumatic here, it's going to be unilateral, so we'll get there. Unilateral, Alright, that was the first break session, guys. We're doing good. Like I said, it gets a little hot in here, so I have to turn on the AC and shut off the mic because it's really, really loud. Okay, so we have different things there. Now again, I just want to finish this before I could go to the break. So we're gonna have, remember, we're gonna be like this, very good. We're gonna have decreased breathing sounds, very good. Tones, percussion, decreased diaphragm, very good. And medium sounds, just radiation towards the like this. And when you have your pleural effusion, when you have your tones, percussion, decreased diaphragm, medium sounds, very good. Good. And then what else you have to have? You're also gonna have your absent pressure. So decreased tone pressure. You're gonna have decreased diaphragm, absent breathing, decreased crackles after pleural growth. Then we're gonna have your lobar lung consolidation or lobar pneumonia. In this case here, we're gonna have your we're gonna have tones, percussion. We're gonna have increased diaphragm. That's a big thing. And you're gonna have you're gonna have alcohol. Good. So we see. Good. And then then we have the diagnosis and yes. In the meantime, while I on break, let's put on my AC so it gets cold in here. See, like I'll let you guys hear it, but it's really loud, not lying. That's just annoying. I don't want to hear. I don't want you guys to hear that. That's annoying. Alright guys, round 2. Fight. Okay. So we have so again, once we do then we do the diagnostic thoracentesis here if we have evidence. Good. 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 Now again, we utilize criteria like we said here, and understand here. Remember that transitive here is going to be less than maybe 7.4, 7.3. This is going to be 7.4 to 7.55 with a pH a little more alkaline here. Good. Now here is that you're also going to have what? You're going to have low glucose in this one, less than 60 or greater. You're good. And then here, remember the LDH levels are going to be lower, less than 200. It's going to be greater than 200%. And then it's going to be more cloudy here. Good. It's going to be more clear. And then clear. And then cholesterol levels here, we're going to be more cholesterol. One of them is going to have, this one's going to have greater than 60 cholesterol, this is going to have less than 40. Something like that, right? No cholesterol levels are going to be, it's going to be less than 45 here again. So less than 45 here, this is going to be less than, greater than 60, good cholesterol. That's why they have the chylothorax, okay? Now we have the pericardium, okay, good. Now when you do you have further workup for your here, is that what you're going to see? So we're going to have, if it's going to be hematocrit greater than 5,000, what does that indicate? That indicates some sort of, okay, that indicates what? That indicates a hemothorax here, good. If you're going to be, your hematocrit here is going to be, half that of the peripheral what? If it's going to be that of the peripheral, hematocrit is going to be, peripheral hematocrit here, good. That's going to be your hemothorax here, good. Good. And then if the pH here is going to be less than 7.2, what we're looking at is going to be your CCM. So malignant effusion here, good. It can also be due to your complicated perineumonic effusion here, good. Or it can be due to your esophageal perforation. It can be due to your cardiovascular disease here, or it can be due to your what's it going to be? NPM. Don't forget NPM as well, good. Now then, what else are we going to have? If you have that's low, so now low glucose here. If you have glucose here less than 60, what's that going to be indicative of? That's going to be indicated of meat here. Which can we see? It can be malignant effusion here, good. It can be due to the empyema here, good. It can be due to your rheumatoid here, your empyema here, or like your rheumatoid, what's it called? Or your autoimmune empyema here. Also can be due to tuberculosis here, or cause infectious tuberculosis empyema as well, good. Low glucose as well, good. Empyema as well. And what else we're going to do? And then we're going to have the cholesterol levels. We'll go back to those as well. So if you're going to have abnormal cytology here, which is going to be malignant effusion, or if you're going to have your malignant effusion, good, or then we have this one. Good, and then malignant effusion is going to be for normal cytology as well. Good. And then we have your, and then we're going to have this as well. Now, when it comes to your, the chylothorax here, to the chylothorax here, so chylothorax is all about cholesterol. So again, the triglyceride levels here. So the triglyceride levels here, good. So triglycerides are over, so it can be over 110 for these. What else are you looking at? 110 here. So your triglycerides there is going to be your chylothorax. What about if it's going to be total cholesterol levels here? It's going to be over what? What's it going to be over 200 here, good. But the cholesterol over 200. Want the cholesterol to cholesterol triglyceride levels is going to be greater than 1. That's going to be your pseudochylothorax here. So again, so when you look at triglycerides over 110, that's going to be your chylothorax here. When you look at your cholesterol, no, it's going to be triglycerides. Now when you look at your cholesterol levels over 200, good, that's going to be your pseudochylothorax, because the cholesterol triglyceride is going to be over greater than 1. And then your total cholesterol is going to be between 55 and 55 and 55 here, and 200. That's going to be your chylothorax as well. And then you can have chylomicrons, fat soluble vitamins here. With chylomicrons, fat soluble vitamins here, good. So if you're going to have your total cholesterol here, it's going to be between what? It's going to be 55 and 200 here, good. Then with cholesterol, then with chylomicrons, fat soluble vitamins, you're looking at chylothorax, good. Now we're going to have different things in terms of. Now, translated makes usually be clear here, and then less, and has low amounts of LDH here, good. Low amounts of cells in blood as well, good. Has low amounts of decreased cell count, good. And LDL, late stage mortality has higher cell count, higher LDH and protein and all that as well. I mean, good. And then pleural fluid here is that with fluid, it's going to be malignant. If it's bloody, it's going to be malignant here, or it's going to be your hemothorax, good. Or abnormal cytology, malignant effusion, good. Then we have good. Good. Now we have treat the underlying cause here. So again, whatever it is here, how do you treat this here? So it's going to be seen how are you actually going to treat this here? So it's going to be caused by congestive. So again, treat the underlying cause for this one. So whatever caused it here. So whatever caused it. So again, if it's going to be caused by congestive heart failure. So if you're going to do acute congestive heart failure, good. I can just say we're going to do diuretics as well. Good. And then also you can do your you can also do your so you can do your therapeutic thoracentesis here, which is going to be chest tube drainage here. You can have any just got to remove perfusion. Good. Renal effusions here should be drained due to high risk of progression. Good. So usually it's going to be treated as oncology heart attack. You can do your therapeutic thoracentesis, like we said, diffusion. Good. Also you can do your should be drained due to high risk of progression of BM. And then complicated here is that high risk. Good. So like that. Good. And then you have tooth thoracostomy. You can also do your paralysis here. Again, you're going to be seeing as well. So again, you can do your tooth thoracostomy. This is here. Good. You can also do your tooth thoracostomy, which is going to be used for remember your company pretty much drained first. Removal of fluid thoracostomy, which is going to be fluid combination with significant coagulation. Good. And then if you're going to have for recurrent perfusions or urgent infections, NPMA, and then drainage of release of fluid, likely clog. Good. So again, we can have your therapeutic thoracentesis here. You can have your tube. You can have your tube thoracostomy. This is going to be due if you're going to have very viscous fluid drainage here, NPMA or hemothorax here. Also for recurrent perfusions. If you're going to have if it's recurrent perfusions here or urgent need for drainage here, it's going to be for thick viscous hemothorax or NPMA or good. Also pleural effusion. If you're going to have pleural effusion here with like hypotension, if you have pleural effusion here with shock here, you can do tube thoracostomy, and then you can do video assisted thoracoscopic surgery and also paralysis. Going to be which is going to be so good. Very currently effusion here again. Good. It should be performed. Have to be for instrument review. That's good. Okay, this one as well. So again, presentation, and then we have this one. So after you do any solid or palpation, you can do a chest X-ray should be formed. Genetic pneumothorax here again. So you're going to do your paralysis here. You're going to do video assisted thoracotomy or paralysis, which you're going to be removal of pleural space. You're going to do a chemical surgery removal of pleural space by you have recurrent malignant diffusion as well. Good. Then we have the subtypes. As well. Good. So we have different things here. The growth factor chart, when you have so it's going to be fair to thrive here, good. Now then, we antibiotics, we already know that here. Okay, yeah, treat the complications here. That you can have meconium ileus here, which usually is going to be fed with meconium within the first 24 to 40 hours here of childbirth. Usually do the obstruction of the limbs with thickened meconium ileus here, good. And then you're going to have vein here, you're going to have biliary vomiting here, good. You're going to have no passage of meconium here, and abdominal distension. How do you diagnose? You're going to do your abdominal X-ray, right? Abdominal X-ray with contrast. You're going to show your dilated bowel here, so bowel lesion, and then you're going to do Barron enema. It's going to show microcolon here, microcolon. That's what you saw. Good. Now, complication that you can have is that you can have your core pulmonale good. You can have your core pulmonale again, and then there's tuberculosis. What else you can do? Good. And then prognosis here, depending on the degree of respiratory infections, your recurrent respiratory infections here. And the happening is that you can do respiratory failure and death because you're going to have mucus pluggings here. And also you're going to have mucus plugging leading to bronchitis and you're going to have progressive. Good. And then prevention here is that remember you can be pneumococcal vaccine as well as your annual influenza vaccine that should affect the children of 6 months old inactivated. And your respiratory failure, good. And then we have complications here. We have your not designed as well, good. Respiratory pulmonary PM edema pneumothorax right out, good. Now we have the meds here again. What happens? Your long-acting beta agonist here is going to cause you to have FATs. It's going to cause you to have hypokalemia, hyperglycemia here, like we said. Also, tremors, right? Tachycardia and arrhythmias here, good. And also get your methoxantine theophylline here. It's going to cause you, probably going to have your nanotherapy to window, but it's going to cause you to have VSHAD, so vomiting here, good. Seizures here, hypotension, arrhythmias here, and tremors, good. Now, we have your sarcoidosis here, which is this can be a type of your interstitial lung disease here, good. Now we're going to have fever here, good. You're going to have weight loss here, arthritis here, and bilateral hyperlipidopathy as well, which we're going to see as well. in addition to the cough, graphic cough here, dyspnea cough, and dyspnea as well. Okay. This. It's going to be usually few 5 women as well. Good. You can see this here. Then here is that you're going to have non-casting granulomas here, and related to lung parenchyma, which are going to be your, without central growth here, which is going to be your, here is that you're going to have your non-casting granulomas here with invading lung parenchyma. These are going to be your multinucleotide cells here without central growth. That's going to be your non-casting granulomas. Good. Now, Lofgren's syndrome here. This could be number 1. Here's that you're going to have your you're going to have a fever here. Good. Plus you're going to have moderate polyarthritis here. You're going to have your erythema nodosum here, which is going to be painful nodules here. In the anterior shin. Also you're going to have your bilateral highly good. Good. Usually associated with a good. You're going to be associated with prognosis as well. Good. Now history here. Remember, you're going to have elevated CD4 to CD8 count here. Good. Elevated and ACE8 and you're going to have hypercalcemia and hypercalciuria as well. Good. You're going to see this as well. Good. And then when you look at sarcoids, what do you see here? Ashwin bodies within the granules, like granules here. Good. You're going to have your rheumatoid like arthritis here. Sarcoidosis. You're going to have your ocular uveitis here, like we said. You're also going to have your hypercalcemia due to increased 125 dihydroxyvitamin D activation here. Good. You're also going to have increased vitamin D activation due to the 1-alpha hydroxylase in the macrophages as well. And also you're going to have spontaneous, which are going to be the lupus here, melasma, which is going to be butterfly rash. And also you're going to have the erythema, nodosum pain, and all those good as well. Now, off your agenda here, just remember you can do NSAIDs here, good supportive care here. Then what are you going to do for your sarcoidosis here? Here's that you're going to use your what? Here's that we're going to use your, then if that, you're going to use good. Now again, we look at the history of illness here in terms of associated with lupus and Bell's palsy, like we said. And usually first you're going to do it, usually found your chest x-ray. If it's asymptomatic here, you don't need to do the you need the high resolution CT, but you don't have to do the bronchial biopsy here. You just need to, you don't need to do no treatment necessary. No treatment necessary as well. Good. So here's that you're going to do the chest x-ray. Is going to show what? It's going to show what? It's going to show your calcified high lymph nodes here. Good. And also you're going to have your calcified high lymph nodes up here. Good. And also you're going to have your upper lobe cavitation here. Good. In particular pacification to upper lobe. So again, be reticular pacification up your nose here with the end. Good. Good. And then you have to do high resolution CT. Good. And then you have to do biopsy. It's going to show non-casting granulomas here. It's going to be diagnostic as well. And then pulmonary function test here. It's going to be reduced tickle here. Good. And you're going to have an increase or normal FEV1. Good. And then the findings here, like we said. And then as well. And then asymptomatic here is also symptomatic here. Prednisone here. Good. And then respiratory conditions. And then respiratory here. You can do methotrexate here, or you can do tinnitus as well. Good. As I find tinnitus. Good. You're going to have bilateral reticular as well. Now, what do we have here? We have pneumonia, 651. Okay. We have this for pneumonia. Good. Now, the cause of pneumonia here, we're going to have bacterial, fungal, or viral causes. Right? Good. So you're going to have bacterial, fungal, or viral infection, right, of the lung parenchyma. So you can see that's all good. Now we have the conditions here. Is that we're in a different condition here? Good. Now project condition. It's going to be your PNP. Good. So it's going to be your fever. Good. You can also have fever. Good. Fever here. Good. You're going to have productive cough here, which is going to be purulent. Productive cough here, which is yellow green spot. With the yellow green spot here. Good. Purulent. Good. Rheumatopsis here. You're going to have nitrolysis symptomatic chest pain. Good. PNP, productive cough here, purulent here, yellow green spot over here, rheumatopsis, nitrolysis symptomatic chest pain, without your good onset fever, and also your dyspnea as well. Good. And some symptoms of and older and good. May be so like we found older and cell as well. Good. The type of presentation here is that you're going to have usually be seen what? You're going to have gradual onset. You're going to have gradual onset. You're going to have gradual onset here, dry cough, headaches, body aches. So dry cough here, headaches, body aches here, sore throat, and GI symptoms. Can be usually seen viral. Good. So viral, right? Atypical is going to be your viral pneumonia. Good. Usually gradual onset. You're going to have a dry cough, headaches, body aches here. And usually with GI, sore throat, and GI symptoms as well. Good. Good. Can be seen viral pneumonia there. Good. With the disorder that we say as well. Good. Legion, like we said as well. Good. Good. So here you're gonna have your more growing onset, headaches, body aches here. Good. Sore throat, GI symptoms here. Good. Viral causes as well. Typical. You're seeing it in your Legionella. Legionella here. Good. AC unit here. AC unit here. Legionella or Mycoplasma Legionella here. With an AC unit here. Mycoplasma pneumonia or Clostridium pneumonia. Clostridium pneumonia. Good. Or your Legionella pneumonia. Good. We have this going here. Okay. Elimination, and then on exam here, when you look at this, you see we have your typical bacteria here, got atypical bacteria, then we have your physical usually going to be caused by like a virus here, usually viral causes here, atypical here, like Legionella, pneumonia, Clostridium pneumonia as well, good. AC unit as well. And then when you look at these, what's going to happen? Yeah, good. So we have one exam here. You're gonna have lung dilation shows what? Decrease broncho breathing here. Decrease broncho breathing. You have decreased breathing or not breathing. Good. You can have rales, wheezing, dyspnea, respiratory. You can have rales, wheezing here, dollars percussion, egophony, and increased that. They're good. Like we said. Good. See that? So again, when you look at this here on exam here, good. So exam, you're gonna have what? You're gonna have what do you see here? So you're gonna have decreased or absent. You're gonna decrease breathing here, decrease your bronchial breathing. You said rales, wheezing here, good. Dollars percussion, egophony here, and increased diaphragm. We said well, good. And then we're gonna have very good. That we said as well. And then we have on exam. We said. And then we have different things. So we have that increases or sharpens or everything being as well. Good. And then we have different things. And then we have chest X-ray. Good. So you can have bacterial. So then we have bacterial or viral or fungal infection or parenchymal, like we said. Band-aids. So you're gonna have further chest pain here. Good. You're gonna have productive cough here, yellow green spot sometimes with abscess here, with night sweats here, and particular chest pain with acute onset of a fever here, and also dyspnea. And then more subtler and in older individuals. And then atypical here is more gradual onset here. You're gonna have headaches here, body aches here, sore throat, and GI symptoms here, usually caused by atypical bacteria. Good. Can be a Legionella pneumonia, basically pneumonia here, and also also viral causes as well. Good. Viral as well. Now when you look at this here, what you're going to see is that you're going to have your rales, you're going to have wheezing here, you're going to have tones percussing, you're going to have decrease or bronchial breathing here, and also you're going to have increased diaphragm. That's good. Egophony diaphragm as well. Good. Then we're going to have the actual, then we have everything's here. The typical bacteria that can cause is going to do it. Good. So those are going to shut the gas pneumonia, but you're going to go spot. So here we're good. Here's going to shut the gas pneumonia. Good. Like we said as well. Now we have the diagnosis from pneumonia is going to be made in the settings of good. So as you do it here is the best initial test here is you can do chest X-ray, which is going to show what? Chest X-ray, which is going to show what? Chest X-ray is going to show diagnostic testing. It's going to show an old man who has show left lower classification here. Good. Left lower classification here. Good. Okay. Chest X-ray is going to be chest X-ray is mirrors with that. But reveal does not reveal clear infiltrate. But if you have no clear clear infiltrate with no under that, you have no CT in chest. Convert information as well. First off, what you're going to do is you're going to do chest X-ray. Good. You're going to look for classification. You're going to look you have no clear, you have high resolution CT as well. Good. And then severe illness can be determined by importance. Good. Now good. Now your curves divide routine blood pressure. Good. Remember, you're gonna do routine blood work here. You're gonna do CBC here, CBC based on CBC based on outpatient here. Good. And then you have to do outpatient clinic, and then here as well. Good. And then here 365 from the criteria. So again, it's going to be, so you do CBC here, good, and no spinning block for all patients as well. Then we're going to have outpatient and patient setting. Outpatient settings here, what are you doing? If that can be done. It can be considered if their candidates for their and doing the outpatient testing for the desk to supplement here if not. Otherwise, no additional workups here unless there's good. Unless they're needed to. And then for patients here, have 5 patients here, so the group 65. If they have confusion here, if they have 3 to 4, 3 or more, then or 4, greater than 4 is ICU admission. So you're going to have confusion here if they have a remount, it's going to be your type unit rate 19. Or it's going to have your respiration rate, it's going to be unit 30. If you're going to have blood pressure, solid blood pressure less than 90 here, or diastolic less than 60, and if age 65 years old, that's going to be ICU. Good. So things are active. Your urine be less than 19. Your respiration rate at 30 here, or blood pressure is going to be less than 90, systolic or less than 60 diastolic. Good, or 365, 65 years old here, that's going to be at 3 to 4 here, that's going to be greater than 4 in ICU as well. Good. Now for half the patients, what do you have to do? You have to do BGR last here, so you're going to do blood, you're going to do blood cultures, gram stain, and also respiratory testing. So they do not good, and so blood cultures here, gram stain, respiratory BGR, lost lymph testing, and your restricted testing, not good. You know, testing, good, we've seen as well. Good. So then, and then we have the causes, good, we said this as well. Now we have, and then treat this here in terms of pneumonia treatment, answer as well. We're going to do that. Now remember Staphylococcus, and we have the cause of hospital pneumonia. Let's go through this here. So, causes of hospital pneumonia. Here's going to be your typical material. It's going to be Staphylococcus aureus here. So that's your note. It's going to be Streptococcus pneumonia here, which is the rest color button. And then again, Streptococcus pneumonia. Staphylococcus aureus is going to be so it's going to be Streptococcus pneumonia, which is going to be your gram-positive diplococci again. So your Streptococcus pneumonia here, good, West Coast bottom. You're going to have West Coast bottom. And what else you're going to have? And also you're going to have your gram-positive lanceolate diplococci, gram-positive diplococci, lanceolate shaped diplococci. And then you're going to have your Staphylococcus aureus here, which is going to be gram-positive again. It's going to be berries, clusters, gram-positive here, clusters as well, good. Clusters as well. And then you're going to have with your first bottom here, so typical material, and then more together else. Good. And then typical, then we have viral here. It's going to be viral here. It's going to be your influenza. Now again, what are the causes of your hospital pneumonia? Good. Usually typical is going to be here. Streptococcus pneumonia here, good. It's going to be rose colored spot here, good. It's going to be gram-positive, lanceolate diplococci, good. And you're going to have Staphylococcus aureus again, which is this one. Which is going to be Staphylococcus aureus, which is going to be your gram-positive clusters, good. And then you're going to be changing the clusters here. And then you're going to have your hemophilus 1A, good. And then more second, also your Streptococcus, good. Good. Typical is going to be Legionella, Legionella pneumonia here, and Clostridium pneumonia as well. And then your respiratory is going to be influenza A, and B, COVID, good, coronavirus, good. Now, we have, okay, so when you have pleural effusion here, this is going to be acute fluid accumulation within a pleural space as well, good. Now you can have pleural effusion as a transitive here, egg-dated effusion, good. Transitive here, understand that in this case here, that when you do your, let's get to this point. So first off, you expect your pleural effusion here, you're going to do a chest x-ray, good. What are you going to see? You're going to see, if it's going to be, you're going to have to see your, you're going to have to go to phrenic angle blunting here and lateral stapes position, like we said. In addition to that, again, that's one, good. And also, if it's a large enough effusion here, you're going to see a consolidation. You're going to see tracheomesound deviation away from the effusion as well, good. That's what you're going to see as well, good. And from there, you're going to do a diagnostic thoracentesis or paracentesis here, and you're going to look at the pleural fluid. And then if you're going to meet the it's going to be none of the following. It's going to be your pleural LDH here is going to be less than 0.6 of the 0.6 or less here of the serum LDH here. Protein is less than 0.5, and then it's going to be less than 2/3 of the approach shot. Good. It's going to be the opposite. It's going to be true. Opposite is going to be true for the exudative. Good. Then transitive fluid is going to be due to two things: increase in your hydrostatic pressure, blood pressure, or decrease in your capillary glycolytic pressure as well. This can do nephrotic syndrome here, or your cirrhosis here, which is going to be your hepatic biliary effusion. You're going to have cirrhosis, you're going to be hepatic hydrothorax here. Good. And then also, what are they go? You have increased heart failure, good. And then what about the other one here? This is going to be, we have increased capillary permeability here. And like we said, it can be due to IPA, it can be due to malignancy here, good, like lung cancer, mesothelioma. It can be autoimmune here, which can be cardiovascular disease here, such as what? Let's name them. They can be your autoimmune, like rheumatoid arthritis here, good, seventh rheumatis here. It can be either the chylothorax here, pseudocylothorax here, hemothorax here, and also your pancreatitis can cause it as well. It can also be due because you're going to have pulmonary embolism here, and also infectious causes like tuberculosis here. When you have your pneumonia here, it can be pneumonic effusion here, good, pneumonic effusion as well. That's been also trauma. Don't forget trauma as well too. So also actually get unfit any of those as well. Now again, what do you see here? So again, you're going to see your DP. So you're going to have dry cough here, non-productive cough. You're also going to have pruritic chest pain. And also you're going to have dyspnea as well. And also you're going to have your pleural friction run. And then you're going to have your dullness of percussion. What do you see here? Okay, let's go with this. You're going to have your dullness of percussion. Let me say that as well. Good. You have decreased acid breathing sounds here. You're going to have your acid breathing sounds as well. You're going to have your immediate, if it's a large effusion, your immediate sound shift away. It's going to be away from the deviation as well. Good. And we're going to have your reduced diaphragmatis here. You're going to have reduced attenuation of voice, and you're going to have absent crackle. You're going to have absent crackle as well. Good. Absent crackle as well. Good. And then that's what we're going to see as well. And then okay, good. And then we have. So we did the overview and the new features here. And then here, is there electasis here? What are you going to see? Electasis here, you're going to see decreased dullness of percussion here, decreased acid breathing sounds here, decreased diaphragmatis here. And also you're going to see your mediastinal shift or your deviation towards the collapsed lung, right? Towards the electasis level, good. And then you're going to have absent decreased voice range, good. And when you have low bar lung consolidations or low bar pneumonia here, what happens here? And then you're going to have hyperresonance here. That's when they have next slide. You're going to have hyperresonance on pneumothorax. So what do you see? Hyperresonance here again. What else are you going to have? You have decreased acid breathing sounds here. Percussion, you're going to have your absent crackles, reduced volume, all that. Lung stimulation here, then you're going to have the dullness percussion. You're going to have your diaphragmatis here. Pneumonia, increased diaphragmatis here. You're going to have bronchial breathing or no breathing here, good. You're going to have egophonia, bronchophonia here, good. And crackles also present, good. Now, that's going to be the table. Now, diagnosis here. So, once we do this one, understand here, we have transitive here. Transitive here, understand the pH can be more affine, 7.4, 7.5 here. This can be 7.4, 7.3. Good. And then this can be higher cholesterol, concentration less than 200 cholesterol. So we have the chylothorax here. Glucose can be less than 60, it's going to be greater than 60 here. But what else are we looking at? We're looking at the, good. And then what else for the glucose here? And then we're looking at your triglycerides. So we good. LDH and good. Triglycerides going to be greater than 60, less than 45 here, good. 100%. That's all good. Now. Alright, now good LDH here. It's going to be cloudy and it's going to be clear as well. And then here, cholesterol levels here. This is going to be greater than 55. This is going to be less than 40. Yeah, that's what we're good. Cloudy, good. Now, then what do you have to do first here? So again, when you look at your exudative effusion here and the hemoglobin over 5,000, that's going to be hemothorax here. It's going to be your hemoglobin going to be greater than 0.5, the peripheral hemoglobin, and it's going to be hemothorax. Good. Now it's going to be low glucose here, less than 60. We're looking at your malignant effusion here. Good. Looking at your MPMI here. We're looking at your what else? We're looking at your tuberculosis here, tuberculoid effusion here. Good. Also we're looking at your arthritis, rheumatoid arthritis effusion as well. Good. And then what about it's going to be pH less than 0.2. We're looking at your malignant effusion causes here. And also we're looking at your esophageal perforation here. Good. We're looking at your complicated pulmonary effusion here. Good. We're cardiovascular disease here, and also we have NPMI here, NPMI as well. And then we have more cytology of malignant effusion as well. Good. Now, chylothorax here. What happened? Elevated triglycerides in this one. the classifier here, it's going to be greater than 200 cholesterol, you're good, and the cholesterol cholesterol level is going to be greater than 1. Good. Also, you're also going to have your fat soluble vitamins here and your microns. Good. Good. So we have this one as well. And then this is what we do. Good. So the works here, and then we have the other one as well. And then bloody, and then we have bloody is going to be malignant or hematologic. Good. Good. The treatment here is that whatever you want to do here is that you want to treat the underlying cause here. So we have here's our cause here. And you treat food overload here with your lip diuretics. Good. What else do you want to do? Then also you want to do we have a couple things here. You can do your therapeutic thoracostomy, which is going to be drainage, which you can drain the fluid. Remember, you can do your thoracostomy again. You can do your tube thoracostomy if it's more viscous, like an epiema here or hemothorax here. Or you can do or if you have recurring fusion as well. Good. Or it's going to be if you're hemodynamic sensibility. And also you can do your video assisted thoracostomy surgery as well. Also you can do your paradesis paralectomy, which you're going to remove all the pleural space here. If you can have recurrent malignant infusion. Good. And then after that, you want to do a chest X-ray. Make sure you're not introgenic pregnant with that works. Good. Paradesis. Good. Now we have hypersensitive pneumonitis here. This can be a type of interstitial lung disease here due to invasion of the lung parenchyma with non-casting granulomas here, and you're gonna have alveolar thickening here, and you have alveolar thickening and non-casting granulomas invasion of the lung parenchyma as well. Now usually you've seen this here in what? You've seen in like veterinarians here and like pigeons and farmers here who breathe. You can see this in farmers here who breathe the mold in from the hay, and also like pigeon owners and farm veterinarians who breathe in the mold from the pigeon like pellets here and their feathers as well. Good. Okay. And that's what you can see what occurs in history. But the illness here is that within 1 to 6 hours of like exposure, you're gonna have a onset of fever, chills, body aches here, fever, chills, body aches here. So you do body aches here. Good. So look for exposure history. Good. And then chronically, what are you gonna have? You're gonna have usually gonna have like a cough here. Good. You're gonna have fine. Bilateral, reticular, interstitial, reticular nodular ratification as well. You can see intersex right as well. Good. Good. Now, your system reserves to reduce inflammation. And also, it's going to be a type 3 mix, type 3, type 4 integration. We're going to have immunogen and omega. Oh, good. And then I know it says you do chest X-ray as well. Good. We're going to have crackles here. Good. Crackles. So again, first is review paragraphs and good. You have diffuse symmetric, you have diffuse interstitial or reticular classification as well. Good. Now we have COPD, which is going to be new. So COPD here is going to be obstructive lung disease here. So we have this is obstructive lung disease here. Good. It's going to be irreversible here. We're going to have either chronic bronchiectasis here and also your emphysema as well. Good. You're going to have three consecutive months of productive cough here for 2 season. Good. Emphysema. You're going to have distal dilation, destruction, and terminal bronchioles here due to either smoking. It's going to be your central lobe here, good, or upper lobe here, or it's going to be due to alpha-1 antitrypsin deficiency. It's going to be parallel, which is lower lobe. Good. Good. Again, relief. We're going to have emphysema here. We're going to have increase lung compliance here. Good. Increase lung compliance here. Reduce elasticity. Increase compliance. Good. Then remember, and when you have your ventilation, reduce ventilation on perfusion. You're good. So you can see what you're good. Okay. Good. Now we have the history. How you're gonna have your hazard. You're gonna have your barrel chest. Your delivery tension. You're good. And also you're gonna have dyspnea exertion. You're good. You're gonna have muffled breathing sounds. You're gonna have use of accessory muscles while breathing here, and what are you gonna have? You're gonna have your use of accessory muscle breathing. Good. And also you're gonna have your exertion. You're gonna dyspnea exertion, and you're also gonna have your diffuse crackle. Also diffuse crackle. I think what have here is that you're gonna have respiratory. You're gonna have your respiratory alkalosis. You're good. You're gonna have your respiratory acidosis. No, there's no crackles. There's no respiratory acidosis. Good. So you're gonna and then osmosis rate, and expiratory reads. We'll get that. And expiratory reads. Good. Good. And ABG here is that you're gonna have your respiratory acidosis for both here, which are gonna be due to reduce pH here and increase in pH. Okay. Good. Okay. Got respiratory fever, anything like that as well. Diagnosis here. So first thing you're gonna do here is that when you do your pulmonary function test here, it's gonna be obstructive battery again. Emphysema or reduced tick level, that's the only one. And remember when you do your alveolar test here, is that your FEV1 here is less than less than 12% or 2 milliliters. Okay. And then what else can you do? Then you like I said as well. And then when you do chest X-ray, you're gonna have hyperinflation of lungs here. We're gonna have reduced pulmonary vascular markings here. We have your flat diaphragm. What else you're gonna have? You're gonna have thin myocardium, thin heart. Good. Thin myocardium, heart. You have reduced elasticity as well. Good. Well, now your chronic bronchitis here, you're gonna have blue bloaters here because you're gonna have early hypoxia, hypercapnia. The pink puffers here is that you're gonna have late hypercapnia. You're gonna have thin pursed lips here. Good. Good. Sit over here as well. Good. Yeah, good. What's that? Now then we have the good. Now again, understand here that a smoke cessation action there reduce mortality risk, and increase survival risk. And then when you start smoking, that's going to do what? Smoking is actually going to reduce the lung destruction. It's going to reduce the lung destruction as well. Good. And then what slows the lung is going to reduce start smoking as well. Now then, when you look at the other one's going to be less than 6 years old, you're COPD here. Good. Smoking is very good with history of liver disease here and basilar COPD. Good. And then we have this one. Good. And then again, how do you treat this here? So whether it's going to be for your COPD and your emphysema here, good, or your bronchitis, first off, you need to do what? You need to do a pneumococcal vaccine. You're good. Yeah. So smoking cessation, that's one. You're good. Oxygen supplementation here is going to be saturation. Going to be so that saturation is going to be less than so PaO2 less than 60. Good. Or your PaO2 less than 55. Good. So PaO2 less than 88 or your PaO2 less than 55. Good. Less than 88 and all. And then you have to do your pneumococcal vaccine, 15, or it's going to be your pneumococcal vaccine, 20 plus your pneumococcal polysaccharide vaccine, 23. Good. This one, influenza vaccine. And also you want to do your pulmonary rehab, pulmonary rehabilitation, which is going to increase your ability to take the answer. And also it's going to reduce your respiration. Good. Can be respiration as well. Good. And then we have what else? We have your Good. It's going to be seen as well. Then we're going to look at this one. You're going to have less than 1 respiration. Let's see what respiration is. Two or more respirations or one or more respiration for this one. You do your COPD assessment test here. Less than 10 and then greater than 10. Good. So then less than 10 you're good. And the more there we do. Here we do your short activity albuterol, right? Or you can do your short activity Turon or Sama and Sama together as well. Good. And then what about if it's going to be more severe? Greater than 10 you're going to do your greater than 10. Here's that you're going to do your as needed albuterol here plus you need your LAMA or LAMA here. Good. Now you're going to the tropium or your Sama as well. Good. And what about it's going to be on the side? You're going to be as albuterol here. Plus your long between going to be your tropium. And then what about it's going to be your as albuterol and your albuterol plus your LAMA. And so you're going to use your LAMA and LAMA here. It's going to be your shred and your albuterol plus your LAMA here. Something from down here. Good. Now, really good. Now, pneumonia. Now, pneumonia here, this is going to be a bacterial here. It's going to be a viral or fungal infection of lung parenchyma. Good. And then the typical pneumonia here that's present here, which is going to be caused by your Streptococcus pneumonia here, good, which corresponds here. It's going to be treated very positive parenchyma genes here, good, positive parenchyma. And then your staphylococcus here, which is going to be clusters here, or more exotic enterprise here, good. Or you're going to have good, and then you're going to have good, and then your atypical within is going to be your atypical material virus or viral within influenza A and B here, good. It's going to be your Legionella pneumonia here, you can use Clostridium pneumonia, or it's going to be your Mercury pneumonia here, good. It's going to be your atypical, which is good. Can be which has your atypical you're going to have your blood fever, good, and also you're going to have your fever, also you're going to have your PMP, good. You're going to have your chest pain, good. You're going to have your predictive pain, good. You're going to have your nighttime, so you're going to have your good. You're going to have your nighttime sweats here, good. You're going to have dyspnea, you're going to have chest pain, and also you're going to have to really respond to something new that's well good. sore throat, GI pain, good. That's going to be, now usually on the Alexander, what are you going to have? You're going to have normal breathing here, or bronchial breathing, good. You're going to have, what else are you going to have? What else do we see here? We're going to have your breathing. So yeah, here's that where you're going to have, what do we have normal or bronchial breathing here, good. That's one. We're going to have your lobar pneumonia here, good. We're also going to have your lumbar attack. You're going to have your dullness to progression extend here, good. We're going to have evophony, bronchophony as well. And also you're going to have an auscultation. You're going to have rails wheezing. Also you're going to have your good. And also you're going to have on percussion. You're going to have hyperresonance. No. You're going to have good. And you're going to have your increased diaphragms. Forget that. Increased diaphragms. So good. Also you can do chest X-ray, looking for your low lymph dilatations or pathogens. Like you're going to have DD. Good. DD as well. Good. And then good. And after that here, you're just going to be outpatient here, which is supportive care, usually in your routine CBC and baseline panel for everyone as well. And usually treat with, and then if you're a candidate to us, you can do one of this as well. So you're just going to be supportive care as well. Good. Now then, if you're C5 here, it's going to be 3 to 4 year hospitalization. You're here 4 years, you're in the ICU. Going to be fusion, you're at 19. That's for 30, or you're going to have your pressure. Here's 39, good. Let me see. There you do your results. You do your gram sitting, you're good. Respiratory cytowire testing. What else? Blood cultures. Also do your lead node testing here, and your nurse tobacco testing as well. Good. That's what we've seen as well. Now, we have your presentation of your uncomplicated pneumonic event as well. Good. So that's some variants. Good. For the variants of all these. Okay. Pneumonic and everything's here. So what do we have here? Presentation of complicated. We have complicated here and pneumonic fusion and beyond here. Good. So we have your when you have your pneumonic fusion, it's going to be so you have pneumonia here, and pneumonia leads to pneumonic fusion. They can either become complicated here, or also you can have your also your pleural as well. So again, accumulation. Now again, when you have pneumonia here, this can be again your pneumonic fusion. Understand here, this can be accumulation of exudative fluid in the accumulation of exudative fluid in the procavity. This can be accumulation of pus in the procavity. Which is going to be your PMI as well. And then usually it's going to be due to pneumonia, and it's going to be, they're all due to pneumonia usually as well. The characteristic here is going to be exudative fusion without direct bacterial evasion. This is bacterial evasion, with bacterial evasion, it's going to be bacterial evasion and pus. Good. So again, you have one with, you can have exudative fusion here without bacterial evasion, and then here is that you're going to have bacterial evasion. The other one here is that you have colonization as well. How to present in terms of this one is that you're going to have, I know for this one we have your fevers, fevers here, cough, dry cough, and chest recovered. Fevers, and you're going to present with a fever. In this case, you're infection, you have a fever, and a cough here, and chest pain. And then you usually X-ray for this one, and then pleural sign here. Your X-ray, then your pleural PMI, that's going to be your pleural PMI cloudy here. That's going to be your CT, which is going to be split pleural sign. Now diagnostic here is at APM. CC. That's going to be what pH going to be less than 7.2 for this one, like we said. And low glucose here, which is going to be meat here. It's going to be your APM good. It's going to be less than 7.2 here, good. And low glucose less than 60. Low glucose good, and elevated LDH. Pleural appearance, elevated LDH. This is going to be cloudy, elevated LDH here. Low glucose, like we said. Low glucose complicated good, and also you're going to have your pH less than 7.2. It's going to be over 7.2, which is going to be your PMI. Pneumonic fusion here, so on pneumonic fusion is going to be normal local good, elevated LDH here, and then slightly cloudy as well. Everything to be negative, maybe positive, good. Okay, so we look at these here again. It's going to get, remember, it's going to be less than 7.2 here, good. LDH is going to be high, LDH here, good, and low glucose. It's going to be very pleural in appearance as well, good. In this case here, it's going to be less than 7.2 here, good. High LDH here, low glucose still. And it's going to be cloudy, good. It's going to be slightly cloudy here, good, but it's going to be somewhat what we're going to do. And below it was going to be high LDH here and normal to low glucose level as well. And then here is that going to be positive. And systemic antibiotics here prevent. So you want systemic antibiotics here to prevent pneumonia here. When you have your uncomplicated pneumonic fusion here, what are you going to do? You want systemic antibiotics for the complicated here. The complicated pneumonic fusion here, what do we do for this one? Systemic antibiotics here. Then we do antibiotics here plus chest tube, plus chest tube, which is thoracostomy, which is going to be your chest tube, thoracostomy, and then chest tube, thoracostomy as well. Good. So persistent symptoms of pneumonia despite advisory as well. So pneumonic, so you have your copy of an NPMI, your pleural PMI, is that you're gonna have, here's that you're gonna have persistence. You're gonna have persistent symptoms of pneumonia here, good. It's gonna be your, which is gonna be your fever, good. Which is gonna be your fever and dyspnea, good. You're gonna have your productive cough, good. Night sweats here, and for chest pain, despite getting treated with antibiotics, right? Antibiotic treatment, good. And then NPM, a specific location. It's gonna be specific, you're gonna have lock NPM, can have your pleural NPM, it's gonna be locked if you as well, good. And then we have the different charts. And then remember, it's going to be CT, you're going to split spiral sign, which is going to be your pleural and visceral cavity. So thickening, you have a thick split spiral, thickening of your pleural and visceral cavity. Again, good. And then common cause of your us is going to be this one. Good. And then we have this one. And then we have common causes. So again, like this here is that we're going to have so your complicated and your not complicated, non-complicated pleural effusion or pleural effusion. Pneumonic effusion. No, it's complicated, uncomplicated pneumonic effusion here. They're all going to be caused by pneumonia. But this is going to be seen what? This is going to be where you're going to have accumulation of exudative fluid within the pleural space, the pleural cavity. And then here's the accumulation of pus, accumulation of pus in pleural cavity as well. And all pneumonia as well. The etiology. The characteristics here. This is going to be where you're going to have. This is going to be exudative fluid. You're going to have exudative fluid without bacterial invasion. Exudative fluid with bacterial invasion. It's going to be bacterial colonization. Good. You're going to have pneumonia here, so you're going to have your fever here, good. Plus you're going to have your productive cough here, good. And then good, and chest pain, and then imaging here, usually going to X-ray rhythm, CT, which we're going to do split pleural sign, right? You're going to see split pleural sign. Now we're going to be diagnostic. Here's a pleural analysis. It's going to be pleural fluid analysis. It's going to be normal total glucose here, pH equals 7.2. High LDH here. It's going to be slightly cloudy. It's going to be cloudy here, good. High LDH here, low glucose here, good. And also it's going to be less than 7.2, low glucose LDH, and purulent as well, good. Purulent as well. Now you treat this here, and both treat this with antibiotics here, chest tube, thoracostomy. It's going to be some antibiotics as well. Good. Good. Now, we have this one. What's the most common causes of NPM, of your pleural NPM? What's the most common? It's going to be your oral anaerobes, most common. Oral anaerobes here. It's going to be your Prevotella, Fusobacterium, Peptostreptococcus, Prevotella, and Fusobacterium here. Good. Oral anaerobes here, and also your Staphylococcus aureus pneumonia. That's the most common cause here. First is going to be weight loss as well, because split pleural sign. You're going to put the split pleural sign, which is this one. Split pleural sign, let's see if we can see it. The split pleural sign's right here, good. Okay, then we have your non-traumatic hemothorax here, which is going to be, so it's going to be accumulation of blood in the pleural space, hemothorax. Now, what you're going to use to, you're going to have hypotension and tachycardia usually. Then your pleural fluid analysis is going to be elevated hemoglobin 5,000, and it's going to be greater than, then pleural fluid analysis is good, and then also your hematocrit is going to be greater than 0.5 the peripheral hematocrit. And then treatment here for non-traumatic hemothorax here. Non-traumatic hemothorax here is that chest tube insertion, rotation there, chest tube, thoracic as well. However, small can be drained, must be drained to the, because the pleural cavity will clot, and good. Good, so again, when you have your chest tube thoracostomy, you're good, is very important because you're drained. However, small, remember, a hemothorax, however small, it has to be due to a chest tube thoracostomy because it can be clot up, good. Now, we have malignant pleural effusion, which again, you have to understand these are going to be like mesothelias and lung cancers and mesothelia as well. This is going to be caused by what? Where you're going to have, remember, you're going to have normal cell cytology, you're going to have cancer related, you're going to have disruption, increase, again, it's going to be increase in your increase cancer cells, increase permeation of increase in your permeability of the capillaries here, and tumor cells as well. Okay. And then we have, what's good, and then we're going to have, we have these features, which is going to be pH here, low glucose here, good, like we said here, good, and high LDH here, low glucose, and pH less than 7.2. And then we look at, it's going to be your CAP NA, which is going to be cell-rich exudative effusion. Alright. Alright guys, I think that's enough for today. It's 3:30 a.m. Yeah, so anyway guys, like I said, thank you for talking to me early. Thank you for listening to me, I should say. I know it's kind of weird to say because I'm a camera, but at the same time, man, it's like I'm someone's, I don't know, it's like someone's listening, you know? maybe you guys should do it too if you ever want to, like, if you have a lot of problems or whatever, if you're having a bad day, just talk to the camera, then pretend someone's listening. That's what I'm doing, but I know someone out there maybe. In any case, guys, hopefully I'll get better at making these things and they'll be a little better for you guys, less noisy, and maybe I can cool the room a little better. But in any case, good night, guys. Take care.